Welcome to this presentation on thrombolysis guidelines in stroke and acute myocardial infarction. This is not just about medical protocols. It's about urgency, about saving lives when every single minute counts. In the next few slides, we'll walk through how timely recognition and treatment can turn tragedies into recoveries. What is a stroke? A stroke is essentially an attack on the brain. It happens when blood flow to part of the brain is blocked, or when a blood vessel bursts. We classify them into two main types: ischemic stroke caused by blockage and hemorrhagic stroke caused by bleeding. There's also a mini-stroke called TIA, where symptoms last less than 24 hours. But whether major or minor, every stroke is a warning sign, a signal that the brain is in danger. Why early diagnosis matters. When stroke begins, the brain does not wait. Cells start dying within minutes. That's why we say, time is brain. The earlier the diagnosis, the better the outcome. Early treatment improves survival, reduces disability, and gives patients the best chance of regaining independence. Every minute lost is brain lost. Time is brain. To understand the urgency, look at these numbers. Every hour without treatment leads to the loss of 120 million neurons, 830 billion synapses, and more than 700 kilometers of nerve fibers. That equals almost 3.5 years of brain aging in just 1 hour. This is why quick recognition tools like FAST are so vital, because speed doesn't just save time, it saves years of life. Common stroke symptoms. The brain signals its distress through symptoms. Sudden weakness or numbness, often on one side, difficulty speaking or understanding, vision problems, dizziness or imbalance, or a severe, unexplained headache. These are not symptoms to ignore. They are urgent warnings, and acting on them quickly can change everything. FAST acronym. The FAST test is one of the simplest ways to identify stroke. F for face. Ask the person to smile. Does one side droop? A for arms. Ask them to raise both arms. Does one drift downward? S for speech. Is it slurred or strange? And T for time. Call emergency services immediately. FAST is not just an acronym, it's a life-saving checklist. B-FAST acronym. An extended version is B-FAST. B for balance, sudden loss of balance. E for eyes, sudden vision changes. Then face, arms, speech, and time as before. Just 2 extra letters. But they can help us catch strokes earlier and act even faster. Risk factors. Why do strokes occur? The most common risk factors include high blood pressure, diabetes, smoking, obesity, atrial fibrillation, and family history. These are preventable or manageable. By addressing them early, countless strokes can be avoided altogether. Diagnostic tools. When stroke is suspected, rapid and accurate diagnosis is critical. CT scans and MRI identify the type and location. Blood tests rule out other conditions. Carotid ultrasound can detect narrowed arteries. And echocardiography checks for heart-related causes. Every test adds clarity, guiding us toward the right treatment. Stroke localization overview. Localizing the stroke tells us which part of the brain is affected. This helps explain the symptoms, guides treatment decisions, and shapes rehabilitation strategies. It's like drawing a map of the battlefield before planning the rescue. Emergency imaging protocols. Imaging is the cornerstone of acute stroke management. The first step, a non-contrast CT or MRI to rule out hemorrhage. CT is usually preferred for speed. Next, vascular imaging like CTA or MRA helps detect large vessel occlusion. Ideally, we combine CT, CTA, and MRI. But even a simple CT with CTA can be enough in emergencies. In stroke care, clarity and speed go hand in hand. NIHS score. The NIH stroke scale measures severity. A score above 6 usually makes a patient eligible for thrombolysis if within the 4.5-hour window. If the score is 5 or less, treatment is reserved for disabling deficits. And when scores exceed 25, we proceed carefully and individualize the decision. It's a structured way of making critical choices. Endovascular thrombectomy or EVT. For large vessel blockages, thrombectomy has changed the game. The criteria include NIHSS over 6, aspects over 6, onset within 6 hours, and an infarct core smaller than 70 milliliters. Thanks to advances like the DAWN trial, thrombectomy can now be effective even up to 24 hours in select patients. This is where we say imaging is brain. Therapeutic modalities in ischemic stroke. In ischemic stroke, the standard therapy is intravenous thrombolysis with Alteplase or rtPA. The window is within 4.5 hours, given as 0.9 milligrams per kilogram, maximum 90 milligrams with 10% as bolus and the rest over 1 hour. More than half of patients regain functional independence with this treatment. There is a small risk of bleeding, but the benefits are significant. In selected cases, advanced imaging allows treatment to extend up to 9 hours. Alternate thrombolytic, Tenecteplase or TNK. Tenecteplase or TNK is a newer option. It's a modified form of tPA with longer duration and higher clot affinity. The big advantage, it's given as a single intravenous bolus, 0.25 milligram per kilogram, up to a maximum of 25 milligram. Western guidelines prefer it, especially as a bridge to thrombectomy. In India, however, its use is limited to the first 3 hours. Simple, effective, and promising. TNK is an important alternative in stroke care. Conservative management in acute stroke. Not every patient is eligible for thrombolysis. For them, supportive and conservative care becomes the backbone of treatment. We start with the basics, maintaining airway, breathing, and circulation. Blood pressure is carefully managed. We avoid lowering it aggressively unless it exceeds 220/120. Aspirin, given within the first 24 hours if no bleeding is present, helps prevent further clots. Blood sugar is controlled, hydration is balanced, and fever is promptly treated. Deep vein thrombosis prophylaxis, nutrition support, and early rehabilitation all play a role. Even without thrombolysis, good supportive care can protect life and preserve dignity. Post-thrombolysis care in ischemic stroke. When thrombolysis is done, the next 24 hours are critical, a golden period of vigilance. Patients are monitored in a stroke unit or ICU. Neurological checks and vital signs are observed closely. Blood pressure is kept below 180/105, avoiding sudden swings. No antiplatelet or anticoagulant is given until repeat imaging rules out bleeding. Glucose is controlled, fever is treated, and oxygenation maintained. A follow-up CT or MRI is done at 24 hours. And rehabilitation begins early, because recovery is not just about survival, it's about regaining life. Acute intracerebral hemorrhage or ICH. When stroke is caused by bleeding rather than blockage, the priorities shift. Blood pressure must be lowered quickly but carefully to a target of 130/150 within the first hour. Intermittent pneumatic compression helps prevent clots in immobile patients. Low-dose heparin or LMWH may be considered after 24 to 48 hours if safe. Surgery may also have a role. Minimally invasive evacuation can reduce mortality in selected cases. Every decision balances risks and benefits, with the single goal of giving the patient a chance at recovery. Take-home points for stroke. Let's pause and take home the essentials. Intravenous tPA is the gold standard within 4.5 hours, extendable to 9 hours with advanced imaging. Mechanical thrombectomy can be life-saving up to 24 hours in select cases. CT plus CTA remains the practical diagnostic backbone. For intracerebral hemorrhage, early, controlled blood pressure management and careful consideration of interventions are vital. And above all, early recognition saves lives, because every minute counts. Background: myocardial infarction. Now let's shift our focus to the heart. In India, nearly 2.5 million people suffer a heart attack every year. Mortality remains high, about 15%. In West Bengal alone, tens of thousands of cases occur annually. Behind each number is a life interrupted, a family devastated. And just as with stroke, time is critical, because here, time is muscle. Initial evaluation of chest pain. When a patient comes with chest pain, evaluation must begin immediately. An ECG within minutes, troponin test within hours, a chest X-ray if needed. Risk factors like diabetes, hypertension, family history, smoking, or alcohol use all add to the picture. The goal is simple: never miss a heart attack, because hesitation costs heart muscle and lives. Time is muscle. Just as we say time is brain in stroke, in myocardial infarction, we say time is muscle. Every minute of delay means more heart muscle dies. The first 90 minutes are critical for reperfusion therapy, whether through thrombolysis or angioplasty. Beyond 6 hours, the risk of permanent damage rises steeply. The message is clear: when chest pain strikes, act immediately. Localization of thrombosis in STEMI. ECG is our window into the heart. ST elevation in contiguous leads points to STEMI. The criteria vary slightly between men and women and across age groups. ST depression and T-wave inversion provide further clues. A simple tracing on paper can reveal a life-threatening clot and guide us to act fast. Remember, new onset, LBBB or RBBB. Certain ECG patterns should raise alarm bells. New onset left bundle branch block with chest pain strongly suggests acute myocardial infarction. New right bundle branch block, though less common, often means serious anterior MI from LAD occlusion. Both carry a worse prognosis, higher risk of mortality, pump failure, and arrhythmias. In other words, these ECG findings must never be ignored. Management of STEMI within 12 hours. When STEMI is diagnosed within 12 hours, action must be swift. The loading dose includes aspirin, clopidogrel, and a high-dose statin. In younger patients, full doses are given. In those above 75, clopidogrel is reduced. Thrombolysis is initiated if PCI is not immediately available. These steps buy time and protect the heart until definitive care can be delivered. Thrombolysis. Contraindications. Of course, not every patient can receive thrombolysis. Absolute contraindications include active bleeding, recent major surgery, uncontrolled hypertension, or previous hemorrhagic stroke. Knowing when not to thrombolyze is just as important as knowing when to give it. The risks must never outweigh the potential benefits. Thrombolytic agents. Two main agents are used: streptokinase and tenecteplase. Streptokinase is given as an infusion over 45 minutes. Tenecteplase, in contrast, is a single intravenous bolus, dosed by weight. In older patients, especially above 75, doses are reduced to minimize risk. If streptokinase was used within the past 6 months, Tenecteplase is preferred. Both drugs, given at the right time, can save heart muscle and save lives. Anticoagulation protocol. After thrombolysis, anticoagulation is crucial. With streptokinase, heparin or enoxaparin is started 6 hours later. With tenecteplase, enoxaparin is given even before the thrombolytic, followed by regular subcutaneous doses. The aim is to keep the artery open and prevent new clots while carefully balancing the risk of bleeding. Management based on duration. Time from symptom onset determines our strategy. Within 12 hours, thrombolysis or PCI are the treatments of choice. Between 12 and 24 hours, thrombolysis is considered only in selected cases: younger patients with ongoing chest pain or unstable circulation. Beyond 24 hours, thrombolysis is no longer useful. We continue with medication, anticoagulation, and supportive care. The clock truly defines the options. Maintenance therapy. After the acute phase, maintenance therapy is the foundation of long-term recovery. Dual antiplatelets, aspirin and clopidogrel, continue daily. A high-dose statin helps stabilize plaques. Supportive therapies include beta blockers, ACE inhibitors, and diuretics when needed. In shock, vasopressors like noradrenaline may be life-saving. This stage is not just about treatment. It's about protecting the heart for the future. Special ECG-based management. Different heart attacks call for different strategies. In anterior wall MI, beta blockers and ACE inhibitors are central. Diuretics may also be required if heart failure develops. In inferior wall MI, nitrates and diuretics should be avoided if the right ventricle is involved. Instead, fluids help maintain preload. And in cases of AV block, atropine may be life-saving. ECG doesn't just diagnose, it guides our entire approach. Supportive therapy in AMI? Beyond thrombolysis and anticoagulation, supportive therapy carries patients through recovery. Antiplatelets, statins, beta blockers, ACE inhibitors, and diuretics all have their place. If blood pressure drops dangerously, vasopressors may be needed. Every drug has a role, and together they help stabilize the heart, restore function, and give patients a second chance. Why nitrates and diuretics are avoided in RVMI. In right ventricular infarction, the heart depends on filling pressure, or preload. Nitrates and diuretics reduce preload. The result? A dangerous fall in blood pressure, worsening shock. That's why they must be avoided and fluids given instead. It's a simple principle, but one that can save a life. Pain and miscellaneous management. Pain adds to the burden of a heart attack and must be managed. Morphine, often with ondansetron, provides relief. Myocardial may also be used. Other supportive medications include proton pump inhibitors, mild sedatives, and laxatives. For diabetic patients, newer agents like dapagliflozin or empagliflozin can be added. Here, comfort and safety go hand in hand with survival. In ongoing severe pain, morphine remains the standard. Myocardial, whether as tablets or infusion, may also help. Routine medications like pantoprazole and alprazolam address gastric and anxiety issues. And in patients with diabetes, modern glucose-lowering agents improve both heart and kidney outcomes. Managing these details ensures care that is complete, not just life-saving, but life-supporting. TNK versus Alteplase. Studies show that Tenecteplase performs just as well as Alteplase in terms of recovery, safety, and survival. This makes TNK a practical alternative, especially in real-world emergency settings where simplicity and speed are vital. Whichever agent is used, the key remains the same: treat early, treat fast. So, what should we remember? Early diagnosis and standardized protocols reduce mortality. Telemedicine projects like Telecardio ensure timely interventions, even in peripheral centers. Clear guidelines empower healthcare workers at every level. And coordination between hub hospitals and smaller spokes is what makes the system work. In emergencies, teamwork is as important as treatment. Minutes decide miracles. Recognition and reperfusion turn tragedies into recoveries. Stroke and heart attack may strike without warning, but our speed, our vigilance, and our protocols can rewrite the story. Every second matters. Every life matters. And together, through knowledge and action, we can make the difference between loss and hope, between silence and heartbeat, between despair and recovery. Thank you.